Thank you, Assad, and thank you for the coordinators for inviting me to speak. So yes, as many of you, my last meeting I attended was the meeting in March 2020. So this is the first in-person meeting. And just to let you know what it's like on the East Coast at this time of year, the colors are still there, but they're starting to dissipate. So it was a little hard to leave the 2-week time period where we have all the colors. I have no disclaimers, but these are a lot of my opinions and maybe not all of NCI's. So I'll talk about our portfolio announcements, or our portfolio analysis on gastric cancers and early detections, funding detection, or early detections, which we've heard quite a bit about as being important, and then funding opportunities that might be available. And we have heard this, we've seen this already today, or the portfolio analysis, which you can find in the reporter section on NIH, gastric cancer specific funded awards, came out about 18 of them, which is pretty low, and it's about $10 million a year. So it's poor. It's almost embarrassing to put this up. And we saw a little bit of this. This is the type of grants that are funded. So there's not a lot there. And as Assad said, it's not just the lack of us putting money there. It's the applications coming in. It's also about educating the reviewers that this is an important area, because often in a review study section you will hear, well, just treat them with H. pylori or treat the H. pylori and we don't have to do any of this. So there's an education. It's not just to the surgeons and everything, but it's the reviewers that sit on the review panels. They have to learn that this is an important area and that it needs more attention. So funding is over. And it was a week ago, have wine. So we'll talk a little about early detection. We know that early detection will save lives. We've heard that already. And so we can go down that. So I actually work in the Cancer Biomarker Research Group. And so that's our focus, is for early detection, to identify and validate biomarkers that are designed for earlier detection and risk assessments. And we do this by developing consortiums that look at, to create multi-center sites for looking at that. And one of the needs for a successful biomarker study is to have take a collaborative approach. It doesn't work at an R01 level very well. It needs multiple sites of people working together, this group of people talking and sharing samples and ideas. So that's what we do in the biomarkers research groups. And sorry, I missed. There's actually 5 marks there, and I hit one. So these are consortia that we've put together through the cancer biomarker research groups. These are actual multi-center sites that are designed to study early detection, to collect samples, and to develop biomarkers in assays for looking for early detections. And you can find more about them at the Cancer Prevention site. So the EDRN has been doing this for over 20 years now, and it's got a lot of interesting areas. Have not quite brought the gastric cancer applications in, but again, the applications have to get there to come in. We have one on pancreatic cancer, a liver cancer consortium that's, there's actually an RFA out for this one, a liquid biopsy consortium, which I'll show you the RFA on that. And then there's some other trans-NCI consortia that you could see on our website. Biomarker development, it's a pipeline, just like a drug development. You need you need discovery. You need to move from the discovery to identifying the actual ones that work. You need to evaluate them in longitudinal studies and then a clinical evaluation to determine if they're functional in the clinic. And just like a drug study, this costs money, and it's much harder to convince a company to put up money for a biomarker study, although some of our multi-cancer study GRAILs and other companies are thinking about doing it. This is what we promote in terms of how a biomarker study needs to be done. It's done in a phase type work where you discover it in a preclinical applications, you move into a clinical arena where you validate your discoveries. Then we need a retrospective longitudinal study to look at the screen positive type assays, and then we move to a prospective study, which is basically an asymptomatic patients where we can pick up the false positive reports. So all this is time and is money. And so can we develop biomarkers for gastric cancer? Well, we did hear about one this morning that was developed in Singapore that I'm told is actually, they're using it now. It's not being reimbursed by the medical, by the insurance companies, but it is being used. And what that will give us is world information. It'll give us knowledge of how well it works in a actual clinical application, what types of false positives are going to come out, what's the consequence of the false positives that come out. So we're in the beginning stages, but obviously we need more. So for biomarker discovery, we need screening assays. As we've heard, there is no standard of care in the U.S. Where in Asia there is an endoscopy. So when you discover a biomarker, you run it against, to show that it's a true biomarker, you need a positive result to look at. And so that's what we need. And so for colon cancer, the Cologuard was discovered by running tests and looking at people as they're going in for colonoscopy. So you get the answer shortly after you've looked at it and unblinded it. So what we really need is a standard of care, or it's a costly intervention study to do endoscopy kind of things. And so this needs the integrated laboratory approach. As I mentioned earlier, we need a large number of biospecimens collected from multiple sites. The discovery is done on 10s and 20s, but the validations are done on thousands to 10,000s. So we need these large cohorts of people to move them forward. So funding opportunities that are available. So you can do a search in the grants.nih.gov. If you put in gastric cancer, you get nothing. This is what I was supposed to do, is come up and share these with you, and I put this in, and I have nothing to talk about. So again, we can go have wine. But as Assad says, there are the normal mechanisms that are out there that are open to gastric cancer. They're not specific to gastric cancer studies, but they are open. So we recently put out a NOCI. A NOCI is a notice of special interest. That means we want people to look at these already published funding opportunities for specific reasons. So these are not specific to gastric cancer, but these are biomarker-specific type funding opportunities. And so I'll go over a few of them as we go here. So funding opportunity to design These are the general type ones that are open for almost all the time. They're reoccurring funding opportunities. The parent RO1s, the parent NCI type R21 studies and the PO1 type studies. So they can be used for almost any type of research, and so there's the links there. So more interesting for biomarker studies, which I brought up in the NOCIs, is the ones that incorporate business. So the first two are from SBIR. These are designed to, at the early stages, to bring in a business partner. And so you've got a marker in your hand and you don't know what to do, bring in a business partner, get some funding from SBIR, and see if we can move it forward. The last one on there is an RFA. This is for our liquid biopsy consortium. This is a pre-competitive collaboration with liquid biopsy. And this actually requires you to have a corporate or industrial partner. This RFA just came out. It's the current one does not have a gastric cancer partner in it. It's hard. It's very strong liquid biopsy type studies. So whether it's appropriate, this is what we have in liquid biopsies. Validation studies. In this one, we heard some talks earlier about having studies ready to go and how do we move them forward. So these assays are designed if you have you've already validated your marker in the lab, you showed clinical utility, now you need to go to a larger study and with samples that can help validate it either in a phase 2 or phase 3 study. And what our NOCI that I talked about at the front end is designed to do is to bring people together that have the samples with the people together that have the biomarkers. So somebody that has a nice marker that detects gastric cancer at the early stage, which we've heard about together this morning, but may not have enough samples, cohort samples, to run assays, could meet up with people that have samples banked in their freezers. And this funding opportunity is to bring them together so that we can make this work in a more successful manner. This one is about cohorts. We also heard another one about an RFA for cohorts that was just opened, and I think that one's is up and running. But this one is this is a continual cohort, a PAR, which means it's issued for multiple times and it continues with multiple receipt dates. What's new about this one is the 161 one is for building the next generation of cohorts. This is to get together and develop cohorts of samples that can be used for the types of biomarker studies we have. Typically, this funding opportunity was always focused on existing cohorts, but now that we have this one for new next generation so this is a starting point for gastric cancer where we need to put this whole group together to start raising samples and collecting samples the same way, and so that when you go and compare your biomarkers, they're comparable because everything was uniform across the board. We have another NOCI for imaging. This one is about putting AI to images and learning to see if we can learn imaging-based modeling for early detection of abdominal cancers. So a little bit tougher for gastric cancer where the imaging is endoscopy, whereas pancreatic cancer we're using CAT scanning. So we've actually have a few groups that are working in the pancreatic cancer. They're actually putting together imaging repositories. What they've done is they've discovered people. They went into the health records and find people that have pancreatic cancer, and then they go back in their history and find them that were imaged 3 to 5 years ago, had CAT scans, And now they're using AI to look at those imaging to predict which ones actually develop the cancer. So this is the type of funding opportunities that might support. We heard health disparities. These are two funding opportunities that are quite frequently renewed that are focused on health disparities, which is I'm sorry, one is a health disparity, one is also, the other one is a microbiome one. These are more mechanistic studies versus biomarker studies, but they're out there. And then there's another one, an intent to publish. This is coming in the future. Again, not specific to gastric cancer, but it's on the tumor microenvironment, which we heard that might be a critical place to go, what's going on in the stomach in terms of the microenvironment. Finally, most of these are listed on our the DCP, the Division of Cancer Prevention's webpage on the resources. So they're up there and they're changing. This is always a good place to go to look for funding opportunities or to contact Assad or me so we can help you along. So thank you. And